So our first speaker tonight is Professor Brian Devitt, and Brian is going to talk about osteoarthritis and the knee, and then Brian will join us afterwards. Thank you.
Good evening. My name is Brian Devitt. I'm going to speak to you about knee osteoarthritis, what you need to know. So I always like using a picture of a patient with their consent, of course, and this is a lady who I performed a knee replacement on in Australia. And this is 18 months following her knee replacement. We went on a charity walk to Vietnam, and she was able to manage the steep inclines with her new knee, and she was very happy, as you can see on her face. So this is one of the successful patients we've performed a knee replacement on, and the vast majority of people do very well following knee replacement. But when we were in Vietnam, we also came across a number of quotes from Confucius, who is a philosopher, a Chinese philosopher, and this is one of my favorites. It doesn't matter how slow you go as long as you do not stop. And I think it's particularly relevant for dealing with knee osteoarthritis, and I'll talk to you a bit further about that during this talk. So my children always say to me, these are my three children, he said, "Dad, tell me something I don't know." So the purpose of this lecture is to try to inform you about issues of osteoarthritis. So initially, we're going to talk about the basics. What is osteoarthritis and what treatments work? We also want to talk about the evolution of surgery, which is quite interesting. And what does the future hold for the treatment of osteoarthritis? So most people say osteoarthritis, that's just a bit of wear and tear. And it can be just a bit of wear and tear, but it also can be an awful lot worse. Try telling this patient with this right knee that this is just a bit of wear and tear. And this is severe arthritis with lots of bony debris within the knee. But interestingly, the patient was presenting with his left knee as being the sore knee. So you just be amazed what people can put up with during their lives. So people come in all shapes and sizes. And when we see people with osteoarthritis, we see three main varieties of the appearance of someone's legs. First is a normal variety, which is just the straight legs. You see someone with a bow leg deformity, or what we describe as varus, or also people with knock knees, or what we describe as valgus. So these all have different patterns of wear, and that's for us to know as surgeons. And you can often distinguish where the arthritis is going to be based on the shape of a patient's legs. So what treatment works? So when I was going through my leaving cert, we had to do Macbeth. And Macbeth, there's this great line when the witches are around their cauldron. They talk about eye of newt, toe of frog, wool of bat and tongue of dog, adder's fork and blind worm's sting, lizard's leg and howlet's wing, for a charm of powerful trouble, like a hell broth boil and bubble. Well, none of these treatments work for arthritis, unfortunately. And we get told an awful lot of things from patients as, oh, I might try this oil or this treatment. And we have to be very careful as to what treatment we advise people on, because we want to do a recommend treatment that works for patients. I often get asked, should I use turmeric? And I don't really know. The only thing I realize about turmeric is you shouldn't get it on a white shirt because it stains. So we really need to be very careful about what we recommend. So there's been a lot of studies on this, and we've looked at the various conservative treatments and what work. So physical activity, that is very important. Just like Confucius says, you don't want to slow down or you'll stop. So it's really important to maintain your physical activity. We know that weight loss is probably the most effective means of reducing the pain from arthritis. And I'll discuss this a little later. Acupuncture hasn't been shown to be very effective. Massage can be somewhat effective, as we can massage the muscles, which might be a bit tight above or below the knee, which can cause pain. Braces can be sometimes effective, normally in early arthritis. Insoles, likewise, can sometimes offload the side of the knee that can cause trouble. Glucosamine, based on these studies, have said it's not effective, but glucosamine is a very inexpensive medication. And even if it has a placebo effect, it may help someone. I'm just going to bring you back to a little bit of physics. And this is Isaac Newton sitting under that infamous tree in Cambridge when the apple fell on his head. And one of the things we recognize about the treatment of arthritis is the effect of weight loss. So if you take an example, we'll do a bit of maths here. If you're walking, just normal walking, twice your body weight goes through your knee at each step. So if you're walking downhill, up to 4 times your body weight goes through your knee. And if you're running, 8 times your body weight goes through your knee. So if we do a little bit of calculation, if you take a 100 kilogram male, so maybe a male is slightly overweight, 400 kilograms is going through that person's knee walking downhill. If you're considering they're running, that's 800 kilograms. That's just shy of a ton going through the knee when they're running. So for that person to lose 10 kilos, it's 10% less of the body weight going through the knee and 40 kilograms less per knee per step going downhill. So you can see how effective losing weight is. So it's really important to remember that. We also recognize that exercise is important, and we recognize that trying to do exercise that doesn't exacerbate your knee pain is really critical in the early period. So the likes of Pilates is good, or low load exercise like cycling or swimming can be very, very effective to reduce improve the strength of your leg, but also to reduce the pain within your leg. So we really promote that. In terms of pharmacological treatment, then anti-inflammatory medication is effective. And the reason it's effective is that it reduces the swelling within the knee. When you have swelling within your knee, you tend to shut down the muscles around the knee. So they stop working as shock absorbers. So when the muscles stop working, then you tend to get much more impact, particularly walking downstairs. Steroid injection can be helpful, typically if someone has swelling or inflammation within their knee, and it's normally done within the early period. Hyaluronic acid, by these studies, which I quote, has not been found to be very effective in isolation, but we tend to combine it now with steroid, and that can be a little bit more effective. And platelet-rich plasma can be effective in certain cases, typically the early arthritis cases. And then we look at surgical treatment. So that's what most people come to me for, is surgical treatment. So arthroscopic washout. So in the past, they used to call it the wash and go. You come in and get an arthroscopy, wash out some debris and go home. But we realized that that's not effective, really. It doesn't address the arthritis issue. And now we try to avoid that as best we can. We can look at arthroscopic meniscectomy, so taking away the meniscus. Now, in the setting of arthritis, if you have a meniscal tear, we wouldn't do an arthroscopic meniscectomy. But if you've very early arthritis and there's a meniscus tear which is flipped or causing mechanical symptoms, that may be appropriate, but it's done on a case-to-case basis. We also look at osteotomy, and that's where we adjust the alignment of a person's leg to offload the side of the knee that's worn, and that can be effective in some cases, but it's normally in young patients presenting with arthritis. And then joint replacement, which we'll discuss a bit further, is a very, very successful surgery in the right setting at the right time. So I'm just going to discuss some knee replacements now. So what we see here is there's various different ways to do knee replacements. What we found over the past is that we have knee replacements that we can use patient-specific implants. So we get a patient's knee and we can take a CT of that knee and use these cutting blocks to give a specific cut for that individual. Now, they've been found to be, reasonably successful, but no more successful than a high-volume surgeon doing routine knee replacement. So it's important that we don't get carried away with the fads completely. We then look at robotic surgery, and that's seen a huge resurgence, particularly in the US, and that uses what we call navigation. So we can plot that person's knee in space. We can also do a CT scan beforehand. And what it allows us to do is do very accurate cuts with this robotic arm, and it's assisted surgery. So that has been shown to be effective. But in the long-term studies, it's no more effective than someone doing an awful lot of surgery with a lot of experience. So it's important we don't get carried away too much, but there's certainly a role for robotics in knee replacement surgery. We look at all of the companies that supply our implants that we put into patients, and each of these companies has their own robotic offering. And it's important that the surgeon that you go to, that first of all, that they're an experienced surgeon is key, and whether they offer robotics or not is really incidental. I think that they want to be a high volume surgeon, which is really important. I'm going to give you a few case examples now. This is an example of what we would do when a patient comes in to see us, and we get a weight-bearing x-ray of their knees. And this is the right knee and the left knee. So here we see in the right knee that the space between the femur and the tibia is nicely preserved on the outside, but very diminished on the inside. And we see that on both sides. So this person would likely have slightly bow leg deformity. So we know they have arthritis within the region of the inside of the knee. We look at the knee from the side as well, and we see that the space between the kneecap and the front of the knee is slightly tight. So they have arthritis in not just the inside of the knee, but also under the front of the kneecap. But we always would address the patient's symptoms, where they're having pain within that, and that knee is important. We look at this person's MRI scan. We look at from the front of the knee, and we can see the presence of whiteness, which indicates fluid within the knee. But if we look on the inside here, we see whiteness within the bone, which indicates that bone is under severe stress within the knee, and that's where the site of the patient's pain is. So often x-rays are sufficient, but sometimes we have an MRI. It can be effective in terms of us looking further into the knee to get a little bit more idea of what's going on. So this person who's had that X-ray would likely have just that side of the knee replaced. And I'll show you an example of that slightly later. This is another example of a patient of mine who presents with severe pain on the outside of the knee. So slightly different configuration of what we saw. And we see that the space on the outside is largely reduced compared to the space on the inside. And the nice thing about having both of these X-rays is that we could compare both sides. So we see the outside of the knee on the left is nicely preserved, whereas on the right it's reduced. And you see this extra bone has formed here. So this is where the arthritis exists. So in this patient, we see that they've got arthritis under the kneecap as well. So of the 3 compartments in your knee, the inside, the outside, and the front of the knee, 2 of the 3 compartments are affected. So this person is more likely to benefit from a total knee replacement as opposed to a partial knee replacement of just the affected side. So we can see this is what this lady had, and she has a nicely balanced knee, so it looks very much like the other knee. And this is the joint replacement I was using when I took these X-rays in Australia. And you can see it from the side where we've resurfaced the kneecap in addition to the total knee replacement. So this lady went on to do very well after surgery. And once again, we go back to that other X-ray of just the isolated X-ray of arthritis on the inside of the knee. And this is what we would do nowadays, is we do what we call a partial knee replacement. So we just replace the inside of the knee that's affected. So we mentioned about robotics and the role that robotics might have in joint replacement. And it's important to be aware of it. Now I'm going to show you more of another personal image. This is a slightly newer picture or older picture to the previous one of my immediate family, but this is my extended family. So this was taken in Tipperary in 1922. And so I have a vested interest in what the future holds, because my future probably holds a joint replacement for me. This is my grandfather here in the front, Paddy Devitt, and you notice he's wearing no shoes. So this is back in the day when they walked uphill to school both ways in no shoes, literally. And this is his brother, and these are all his brothers. So Paddy had a hip replacement. His brother had a hip replacement. This brother had a hip replacement. This brother had a hip replacement. I'm not sure about the others. I think they may have passed away before getting to that stage. But we realized there's genetics to arthritis. Now, unfortunately, we can't change our genetics, but it's important that this is probably what the future holds, that we'll be able to tell those people who are at risk of developing arthritis and maybe in some way mitigate whether the development of arthritis in those individuals. But I think the key is to maintain your body weight. And that's something that I think we all have some choice over. And I think that's really key. If we have a high risk of developing arthritis, it's important that we look after ourselves as we age. But we're not there yet and quite determine the genetics of arthritis just at this point in time. But what we do know is exercise is very important, and we're getting a lot more smart about using these smart fabrics and being able to identify which muscle groups we're weak in, etc. So the future holds an ability to look at tailor our rehabilitation to further advance our ability to postpone the inevitable joint replacement for some people, and looking how we can fully maximize rehabilitation or prehabilitation. We're about to embark on a joint lab where we look at patients with arthritis pre and post joint replacement to see if we can identify the muscle groups in which they are weak in. And I think this will make great advances in terms of how we manage patients going forward. But we use all of these smart fabrics and technologies in years to come to help us with that. People often ask us about stem cell therapy for knee arthritis, and I think it's really important because we all look for the next great panacea in terms of treating arthritis, and most people are wary, and for good reason, undergoing joint replacement because you can't go back on it. So they look for other lesser modalities. But unfortunately, the literature is just not there in terms of the use of stem cells. In fact, if you look at what the experts say, and this is taken from Australia, where I was working for 10 years, that the position statement saying that the use of stem cells is very complex, and that really we don't understand the effectiveness in arthritis just at this point. But they also say that they would currently not support the evidence to use stem cells treatment as a clinical intervention outside a clinical trial setting. So a lot of these people who peddle the use of stem cells for treating osteoarthritis are not doing it as part of a clinical trial setting. It's for monetary gain only. So it's really important just to be a little bit circumspect about those scenarios. But I think there is potential there, but we have to do it in the setting of clinical trials firstly. So I'm going to finish now with another quote from Confucius, and he said, "Choose a job you love, and you will never have to work a day in your life." And we have a great job in terms of orthopedics because we give people back their mobility, we give them a new lease on life. But it's very important that you only choose to have arthritis when you've exhausted non-operative means, when you've gone through the effective non-operative measures, and then get to the point of a joint replacement, because you'll do much, much better at that point from a rehabilitation perspective. Thank you very much.
Brian, thanks for a really interesting talk. So we covered a lot in that. So we're going to start with some of these questions. So Brona's asking, do you carry out partial knee replacements, and how long do they last, and can they be renewed? And also she's asking, is it keyhole or open? So yeah.
Yes. So I do carry out partial knee replacements, and increasingly more frequently than I used to. And the reason for that is that people tend to do very well with partial knee replacements and do have a slightly quicker recovery. The prosthesis typically lasts in around 15 years or so. And what normally happens is that the other parts of the joint tend to wear out. It is a relatively easy conversion from a partial knee replacement to a total knee replacement. In terms of the recovery, patients, as I said, tend to have quite quick recovery following partial knee replacement. So they're normally walking a little bit more quickly with less pain. In terms of getting back to their normal activities, so it varies, but anywhere between, probably 3 months to up to 6 months. But in general, the partial knee replacement patients are slightly quicker than the total knee replacement patients.
Okay, good. So now somebody else is asking here about knee sleeves, and are they a con, or do they provide some kind of relief for bone on bone?
Yeah, so well, knee sleeves essentially are a dressing, or a sleeve you pull over your knee, so they provide compression to your knee. So they are effective, and essentially they give a bit of feedback to your knee when you have swelling. So they don't necessarily reduce swelling per se, but they give a little bit of support to your knee. When you have bone-on-bone arthritis, they're probably less effective, and typically patients with bone-on-bone arthritis complain of a dull aching pain in their knee. The knee sleeve might provide a little bit of support, but I don't think it's going to eradicate the pain entirely.
Yeah. Okay, good. Do you think robotic surgery is better than manual surgery, or is that the future?
Yeah, it's very interesting. It's an area which I've looked into quite a lot, and I used a lot of robotic surgery when I was working in Australia. And since I've come home, I've reverted back to manual surgery. My outcomes are just the same, and I think that robotics is likely to be the future, but we don't have any compelling evidence to suggest that the outcomes following robotic surgery is any better than surgeons who carry out high volume knee replacement. That means they do a lot of knee replacement. But I think that as we evolve and the next generation of robotic surgery comes in, I think they'll improve things, and I think we'll probably see better results with it in the future. But for now, if I were choosing a surgeon, I would choose a surgeon that does high volume, not necessarily a surgeon that does robotic surgery for having a knee replacement.
Okay, good. There's a few more questions coming in now. How do I know if I have arthritis?
Well, you have a variety of symptoms. I think you suppose you look at the age of the individual. So typically patients who are, towards their middle ages and getting more elderly are patients who are more likely to develop arthritis. It typically presents with pain. So pain at rest or pain at night is one of the hallmarks of arthritis in terms of the symptoms. You tend to have people who have decreased range of motion within their joints is another symptom. And you also see deformity, particularly in knees, when it develops or when arthritis gets worse, but it tends to be based on symptoms. So someone who complains of pain, stiffness, and swelling within a joint.
Okay. Do you find people who have a history of frequent road running present with knee osteoarthritis at an early age versus people who don't engage in road running?
Well, it's very interesting because I think it's a bit of a myth that running causes arthritis. And if you look at the typical body habitus of a runner, or certainly a marathon runner, they're quite skinny people
Yeah.
normally. So they tend to have lower body weight and therefore they're less likely to develop arthritis. But there was a really interesting study a number of years ago that I had to review, which looked at the prevalence of arthritis in a group of marathon runners and found it was actually lower than that of the normal population. So
Okay.
what people often blame running because they revert to running in their 40s and 50s, but they probably played more rigorous sports in their early life, and that's where they took a chunk out of their cartilage. And the
Right.
running just is what caused the end result, or maybe exacerbated it. But typically, people who are active and low body weight tend to have less arthritis than people who are overweight and are more sedentary.
Okay. Actually, someone asked this here: is osteoarthritis more common in people who are obese? Is there a metabolic factor in this development?
Yeah, well, I think it's mentioned in my talk, the very simple equation in terms of how much body weight goes through your knee when you walk.
Yeah.
So, yes, obesity is a big factor. And in fact, losing weight is the best treatment, non-operative treatment for arthritis. So whether there's a metabolic factor or not, I'm not 100% sure if that's proven. But certainly weight is certainly a huge factor.
Okay, there's two questions here actually about bilateral knees. So someone's asking, can you kneel after a bilateral knee replacement?
Yeah, well, let me answer that first. Yeah, so whether it's unilateral or bilateral, you can knee after any knee replacement.
Yeah.
It does feel a bit strange when we typically make an incision, we make it to the front of the knee, and therefore there's a slight numbness on the outside of the incision. So it feels a bit odd when you kneel down. Now, there's no reason you can't kneel on your knee, but it just feels a bit strange. Ironically, when you have bilateral knee replacements, they both feel the same. So it doesn't feel as odd. One doesn't feel different to the other. But someone gave a nice analogy. It's like wearing a pair of sandals at the start of the summer. They chafe a little bit, they feel unusual on your feet, but as your skin hardens up, you're able to manage without any problems. So there's no contraindication to kneeling after any knee replacement.
Okay. So the other question. Okay, so the other one then, someone's here asking about if you need a full knee replacement, is it better to have it sooner rather than later?
Oh, it depends on how bad your symptoms are. And we often have people coming in and saying, oh, I'm better having it when I'm young than waiting till I'm old and I'll be easier to recover. But you need a knee replacement when you need it. And
Yeah.
it's not, I don't want to be facetious, but when you start having pain at night, when you've pain at rest, when it affects your quality of life, and I say to patients, if it's the last thing you think about before you go to bed, if you can't sleep at night, and it's the first thing you think about in the morning because you have pain in your joint, you probably need a joint replacement. So I think based on that, that's really my answer to that question.
Okay. Talking about the bilateral, then someone's just saying, can you just speak about the option of getting them both done at the same time as regarding recovery?
Yeah.
I think it's the
So
recovery time.
obviously we're very selective about the patients we choose to do bilateral knee replacements on. So they have to have, evidence of pain within and arthritis within both joints, and typically they're as bad as each other. The advantages to having them both done are you reduce your rehabilitation time and you're up and running straight away and you don't have to go back and have the second one done. But the disadvantages of it, it's a bit of a bigger undertaking. And as I joke with the patients, you don't have a good leg to stand on. So it can be a little bit more challenging in the early period of rehabilitation. The risks are slightly higher, but they're not significantly higher nowadays. Because we have refined our surgery and it's a fairly quick operation. So doing them both together is under the same anesthesia. So really it's on a case by case basis. But patients who have profound arthritis and have really decreased range of motion tend to do very well when they have bilateral knee replacements done because they can move both legs the same.
Okay. Someone here is saying that they've had 2 arthroscopies done, but their knee is still really sore and uncomfortable. When they twist, their knee hurts, and they're just kind of wondering, I think, where should they go next?
Yeah, so it obviously depends on what age the patient is and what was the indication for the arthroscopy. But we often find people who have had a meniscectomy or had some of the soft tissue cartilage removed from their knee. And if they've done it twice, they would suggest that they've had some ongoing issues with that knee. What typically happens in those situations is the cartilage, the hard cartilage of the knee tends to wear out. And really, in those situations, we'd investigate with weight-bearing X-rays or potentially an MRI to see if the joint has worn out. If the patient is young and it's a relatively isolated to one joint, they may be a candidate for a partial knee replacement, but it's done on an assessment of where the pain is in particular.
Yeah, okay, thank you. Few more questions here. Someone had a triple tibioplasty fracture 2016 with plates and screws and osteotomy later on. They're still in a lot of pain. They're asking what could they have instead of a joint replacement? They do still exercise, they walk, they do Pilates. Is there an alternative, I suppose, at this stage?
Yeah, so I think with any individual like that, you can get post-traumatic arthritis, and that unfortunately afflicts younger people a lot of the time. Yeah. So we would always be loath to go to a knee replacement unless we absolutely had to. The same principles applied as I mentioned in my talk. Looking at maximizing non-operative measures such as body weight, occasional anti-inflammatory medication, maintaining the strength of the knee is really important. If they're not settling with oral anti-inflammatory medication, one could consider an injection of local anesthetic and steroid, or maybe hyaluronic acid can be effective in some cases. If it is a traumatic case with metalwork in place and they're heading for a knee replacement, sometimes even just removing the metalwork can improve some of their symptoms, and that would be necessary before a joint replacement, and indeed advisable before a joint replacement. So that might be a temporizing measure to help the person along the way, but we try to do everything to delay a knee replacement typically.
Okay, thank you. Someone's just asked about sports. Are there any sports not recommended post partial or a total knee replacement, example tennis or skiing?
Well, those two examples are good because we don't really there's no contraindication to playing those sports. I suppose if you look at kind of sports that put a high level of load through your knees, such as running or running marathons, you wouldn't really advise that, to be honest with you, after a total knee replacement, and potentially even after a partial knee replacement. But we're very nowadays we're less strict about what we would consider contraindications for people to participate in. When I was living and working in Australia, lots of patients came in, wanted to surf, and that's a fairly rigorous sport if you get very low. So I'd say if they're able to surf, no problem in doing that. But obviously everything comes with risks, but we let people participate in sports. It's good for them.
Okay, and I think it's probably the last question. Is a knee replacement always successful?
No, it's not. And I think that's where we are very particular in terms of choosing patients that were at the right time for knee replacement. And I think one of the important things we spend a long time talking to people about is informed consent. And as part of informed consent, we have to explain the alternative options. And I've mentioned that in my talk, but also the risks related to surgery, which is really important. So I explain to patients that one of the things we're paranoid about is infection, and infection occurs in less than 1% of patients, but we try to do everything we can to avoid that. The other thing which people complain of after knee replacements is stiffness, and we find that patients have to really engage in the rehabilitation. If they don't get engaged, or they have too much pain and they can't engage, then they do become stiff, and that can be a pretty miserable experience for the patient. So we try to do everything we can to mitigate the risk of complications, but unfortunately they do occur. But when they do occur, we tend to treat them very aggressively and very early.
Okay, Brian, thanks very much for joining us.
Thanks very much, Fiona.
And just so people are aware, these talks will be on the website under events as well, if you want to go back or point anyone that way at all. And there are other talks on there on skiing and golf and tennis, etc., which may be helpful to you.